Thank you so much for that beautiful introduction. Can you all hear me okay? All right. I tend to talk softly, so if you can't hear me, just raise your hand, please. And if I talk too fast, you can just say, slow down. Okay. All right. I would like to just start with a little bit of music. And this is a Shruti box. My family comes from India. I was born there. And this is a drone instrument. So I just would like to invite you all to fully arrive here. I know you did much to get here this morning, I'm sure. So you can just rest your gaze or close your eyes, and we'll just take some deep breaths together with the support of the music. If you like, you can hum with me, any tone you feel. Thank you. So I have been so moved since I arrived yesterday morning by the warm welcome of the Assisi team and this beautiful community that you all have. So thank you for being here and for welcoming me as well. So today I'd like to talk about community-supported end-of-life care. And there's a 40-page commission paper that came out I'd like to talk to you about by The Lancet, which is one of the oldest medical journals in the world. Have you all heard of The Lancet 40-page commission? No? Okay, good, wonderful. And then I'd like to share some personal experiences that have really guided me in this direction after being immersed in the allopathic Western medicine medical model. And talk about community-supported end-of-life care. What is it? How does it differ from traditional hospice palliative care? How can communities work intricately with existing models of care? And I'll talk a little bit about what we're doing in the US, and then discuss the model that is based in the US, but also expand that to one of the most famous models for this kind of care in Kerala, India. And then touch on something that's referred to as the public health approach to end-of-life care. So just a little bit about my background and my journey to this work. I know we all have our stories about how we came to be here, and maybe we'll get to hear some during the breaks and lunch. But I was born in India, in North India, Chandigarh. And when I was 8 months old, my parents left via London and Wales and landed in the south of America, the US. I was 3 years old. And I would go back to India, I think the first time was when I was 4, and I had these distinct memories of life being so full and rich in India, and the full spectrum of life was in my field of vision. I saw young children barefoot begging in the streets. I saw elders ill and dying in the streets even, and then I saw everything in between. And I would come back to the US where everything was so manicured, and I couldn't even see elders. Where were they? And death was something nobody talked about, and suffering was something that nobody seemed to experience. Somehow we were impervious to suffering. And I think that left an impression on me in my youth. And then when I was a little bit disconnected. I thought, what are we doing here on this planet? Why am I here? What's the meaning of life? And I had, my parents were Hindu and Sikh, 2 different religions. So religious teachings guided me a little, but it still wasn't rooted in the practical. And people weren't living, there's a separation between religion and spirituality and day-to-day living. So that always struck me. And then when I was 17, so I'm 43 now, 26 years ago, I was in undergraduate college. And I discovered hospice volunteering when I was 17. And when, as an incoming student, they had this big volunteer fair and all these booths set up, and one of them was the Hospice of Charlotte booth, a city in North Carolina. And I went up to the lady and I said, "What is hospice? Can you tell me?" And as she described sitting with people, learning the skills to be with people as they were dying, something resonated deeply with my soul. And I'm assuming many of you know what I'm talking about. How many of you are volunteers? Wow, beautiful. And then others work in the field, is that right? Okay. So I did that. I ended up becoming a volunteer, learning about different ethical principles around end of life, cultural, religious perspectives, and started sitting with people as they were dying. And it changed my whole life in being in that setting. And fast forward, I went to medical school and did that training, which was an immersive experience, and studied family medicine, and then specialized in hospice palliative medicine, which is an extra year of training, and then worked in a 26-bed hospice facility. What you all have here, 80 beds, is quite impressive. And in our country, a 26-bed facility is large. So that was one of the biggest ones in the region. But I did that for 10 years, or 10 plus years, and I'm still doing that part-time. But then, as Juliet mentioned, this man showed up in my life, and he was a patient who was dying in an inpatient hospice during the pandemic, and he really wanted to die in community. But because of circumstances and having moved away from his community to be closer to his other family who could care for him, he couldn't really create that around him. And so I got involved through a friend, a mutual friend, and got him to our community. And then the hospice program wouldn't allow us to video his dying process, which he wanted. He wanted to share with the world his journey to alleviate some of the fear that is so prevalent. And so that's what catalyzed my shift in my career, and it has really brought me here today. And that was in 2021. So that documentary is called The Last Ecstatic Days, and if you're here on Sunday, you'll get to watch it and we'll talk about it. So that put me on this path. Oh, excuse me. I'm pushing all the buttons here. You guys have seen the whole time. And that catalyzed the formation of the Center for Conscious Living and Dying. And I hadn't even heard about, I'd never put the term community-supported end-of-life care together. In my vocab, I didn't have that phrase until I realized what we did for this man, Ethan, was bring together people that wanted to serve and honor a dying man's wish. And that's what we did. And so there is a model of hospice that's called the social model for hospice that's been around for as long as the original hospice was founded. But it is confusing when we say that term, social model for hospice. People don't understand what hospice is. You know, I don't know if you're nodding heads, so it must be similar. So that's a little bit about my journey to this moment. And it's an honor to be here with you all. So the Lancet came out with a 40-page commission paper called The Value of Death, Bringing Death Back into Life. And this paper blew my mind when I first read it. And it talks about, it looks at death globally. And it says that dying in the 21st century is really a paradox, meaning there's contradictory things happening. So in some ways, people are over-treated in hospitals, experiencing highly medicalized deaths. And then in other parts of the world, there's almost no access to comfort meds, opioids, symptom management, and people are suffering. And so that is the reality, and that's kind of a snapshot of how we deal with death and dying in our world. And it's unbalanced. They speak to the imbalance between the way people are dying globally. And something to remember is, you know, as you all know, death can occur in many ways: accidental, conflict, natural disasters, pandemics, violent deaths, suicide and neglect. But what we're talking about this weekend is really the deaths caused by illness and disease. So planned deaths, anticipated deaths. So that's one thing that the Lancet also focuses on. So one thing they acknowledge is that how people die has changed radically over the recent generations. And for many of us, death comes later in life, which means we're often living longer with terminal or chronic illness. And dying is often prolonged because of advancements in medicine. We actually, for example, people with stage 4 cancer can live a lot longer with immunotherapies. I know a woman who's, you all know, who's in her 40s and she has stage 4 breast cancer. She's had it for 8 years and she's on immunotherapy. So dying, she's still dying, but it's prolonged. And then what used to be supported and held by family and community really has been handed over to healthcare professionals. And that's something that has been welcomed, but there has been a cost and an expense as a result. So what happens is, and I'd love to know more about your experience here in Singapore, but I have a feeling it's similar based on what I've read, is that the roles of the families and communities around death and dying have been confused, and people are confused as to how to offer care. How do we actually show up for somebody who's dying? And many people have no exposure to death. So I've taken care of 80-year-olds who've never seen a dying person, somehow. And some of that is also families have spread all over the world, and communities are no longer as involved with this season of life. So just some things to think about. I also want to acknowledge that this Lancet commission paper, one of the authors was Dr. Eric Finkelstein, I think you say his name. He's the director of the Lean Palliative Care Center. So Singapore was represented in that. So when we think about what makes a thoughtful death, you all probably have reflected on this question for yourself, I would imagine, if you're doing this work. Another Lancet paper looked at multiple studies, so meta-systemic review of what qualifies or what do people find meaningful and how do they define a good death. I don't tend to use good death because that's very subjective. What's a good death for you may not be a good death for me, and vice versa. For example, I love being around people, and some people who are private, that might be terrible to have 20 people staring at them, you know? And what I would like you to do as we're going through these is just pay attention to how many of these top 11 elements of a thoughtful death would require medical professionals. Just something to think about. So number 1 is relief from physical pain and other physical symptoms. So that's clear, right? We would like medical involvement, medical attention. Effective communication and relationships with your providers is important. This was a good one too. The performance of cultural, religious, and spiritual rituals was very meaningful and important, and provided a sense of comfort and relief. And then freedom and relief from emotional distress and suffering, psychological suffering. Many people have existential suffering. You know, where do I go? What happens at the moment of death? Autonomy with regards to decision making. So people feel it is important to have a say in what happens to their body, when it happens, how it happens. And they want to have control over their decision making. This is an important one, dying in the preferred location. For most people, that is dying at home. Life not being prolonged unnecessarily. And I'll let you know, I'll get these slides to Alex and the team after, so you'll have them, just so you know. Awareness of the deep significance of what is happening. So this one's interesting because culturally and religiously, there are different ways that people talk about death to the person who's dying. You probably all know. So in some cultures, the person who's dying isn't told they're dying. And that, though it may seem to make sense, I wonder how supportive that really is. But most people who are dying know that they're dying, whether we tell them or not. They're having signs in their bodies that things are changing. And some people just want to know that you know that they're dying. And that opens up a conversation, that I feel safe. I can come to you and tell you my fears. Otherwise, they keep it to themselves. And then I've seen that cause more anxiety, pain, physical symptoms if it's not addressed. So acknowledging what's happening and honoring what's happening as a major life transition can be a gift. Many people are worried about their family and friends. So I want to make sure that they're okay, my loved ones are supported. Not being a burden on anyone. That's a big concern for families and people who are dying. And then the right to die. Some people, it's illegal in many parts of the US, but there are about 11 states now out of 50 that have legalized it. Other parts, like in Switzerland and Belgium, Canada, you can take medicines, ingest medicines to hasten your death. I don't think it's legal here. No, we talked about that yet. So as you see, most conditions for a good death can be offered by many of us in the room without specialized training, without skills, without expensive medical intervention or specialized knowledge. And for some people, this may be a surprise because we often think that in order to show up for people who are dying, we have to be specialists or have extensive experience. Whereas historically, death, dying, and grief were held by the village, the community. And this is an inherent, we all have an inherent knowing and understanding of how to be with someone who's dying, even if we're afraid, and even if we're not familiar with it. Just so you know, this meta-systemic review was looked at mainly high-income countries, and about 16 of them, and less is known about people's preference in lower-income countries, where community is sort of, it's an essential part of life already. So I'll just leave it at that. So I want to share two stories and some images here. You will see people who are dying and dead, so I hope that's comfortable for you all. If not, you can close your eyes. So Paula Brown was one of my dearest friends and companions, and I would call her a mentor. And she also happened to be my mother-in-law. So I married her son. And that's my son, Avi. He's now 8. 3 children. And Paula was diagnosed with pancreatic cancer. And after a year of decline, pancreatic cancer is notorious for, you all know, yes, being insidious. And it's kind of, by the time you find it, it's often too late. Yes, exactly. So that was her situation. Losing weight, studies didn't show anything until it was too late. So Paula lived about 6-hour drive from me and Jay, and she chose to spend her final days with us in our home. And so here she is with her children, surrounded by children. So that's something I started realizing, that you're really living up until your last breath. When we often think of somebody who's dying as just on their way out, and we don't really want to disturb their process, so we kind of limit our connection, interaction, the joy, the celebration. Not all of us, but this is a tendency, not knowing how to relate to somebody who's dying, because it is so painful when you love somebody this deeply. She was definitely the closest person I've said goodbye to in this lifetime. And it's a very powerful experience with her. So she died in her home with hospice care coming in. Home hospice team was wonderful. This is one of her sons holding her hand, and my husband in the back. And you see in the back there's guitar, there's flowers, there's music, there's candlelight, there's dim lighting, just a very loving atmosphere. Oh. And you may be wondering why we have all these pictures. She was the oldest of 7, and her youngest sister was a journalist. So she had her iPad and was taking pictures the whole time. So then people crawled in bed with her and loved on her and hugged her and held her. And that's even something, like how okay is it to touch somebody who's dying? They're frail. You don't want to hurt them. You don't want to cause pain. But beyond that, there's permission if that person allows for it. And here she is, I think right after she took her last breath. And I held her face. I was right there with her. And it was so powerful. And her community came together, and really her family and friends helped us 24/7 to take care of her. I was pregnant with my 3rd, and it would have been a lot if it was just my husband and I, or just her husband. So we had so much love and so much support. People came from out of town, stayed with us. It was a really beautiful experience. Now, after death, I snuck a preview of it, sorry. In our country, we can act like the funeral home. So we have the opportunity to tend to the body as family and friends and prepare her body and keep her in honor for up to 3 days on dry ice or something that keeps the body cool. And then you can transport the body to a funeral home or a crematory or a green burial is what we call it. So green burials are environmentally friendly, natural ways of putting somebody back to the earth. And so that's what she wanted. She didn't want to be in a black bag and swept away into a morgue or a freezer. So she chose to be with us. And you'll see her as we prepared her body. She lay in honor, we call it. And then the children, so this is another thing. Children, they were all invited into the process. We didn't demand that they come. We didn't dissuade them from coming. We said, Sahana, would you like to put flowers on Nana's body? And she said yes. The little one said no. So we honor that. And what we know about how children deal with death, it's more important how we are around death and dying. If we're anxious and nervous and don't know how to be, then they're going to feel that. But if we are more natural and acknowledge that death is a natural process, then they respond. And that's been the case with them. They've been exposed to death since they came into the planet. I was doing it long before they came, so. Sorry. And then this gives everybody an opportunity to grieve and process what has happened. So the children got to do artwork, and people came and said goodbye, and we adorned her with flowers and loved her and did poetry. And then we carried her to the graveside, a hand-dug grave. There's only about 9 to 12 in the US, these kind of conservation green burial grounds, they call it. And here she is shrouded with flowers, and and these are the children next to her body. And then we got to put her in the body and close the grave. And it was one of the most profound experiences for her family and friends. They said, I didn't know we could even do this. I didn't know we could be with somebody like this. How can we get to do it? So the more you experience a death this way, that's not so medicalized and not so procedural oriented, the more you realize that there's other possibilities and ways to be with death. And so there she is. Just in interest of time, I don't know, how are we doing on time? Is it 10? I might skip the next story, especially since you all are going to be, many of you will still be there. So this is another story that really catalyzed. This was Ethan Sisser, the 36-year-old with a brain tumor. And I'll just show you, he was dying in New York City, and then we got him, I'll just quickly show you. You see this view, and nature was very important to him. And here's his mother. And you see candles and ritual and flowers and ceremony, really. The whole experience is very powerful. And his friends made him a pine casket, which is biodegradable. Doesn't cost as much as the fancy ones. I think 80% of people in Singapore are cremated, is what I read. Is that about right? Does that sound right? So burial's not as popular, but. And then we closed the grave and similarly closed it ourselves and honored him that way. So I show you that just to give you an example of a community coming together to support a dying loved one. And the beauty of not having it be overly medicalized. I've known people who choose to be hooked up to tubes and in the ICU until their last breath, and that's their choice. There's no problem with that. But I've also had people, my uncle did that just for his loved ones because he told me they're not ready for me to let go and I can't give up on them, even though I'm ready to go. So he stayed intubated and fighting for life at all costs just for his loved ones. So I always think, what if the family was more comfortable with this natural process? Would that have changed his dying experience? So we'll have time for questions at the end as well. Just wanted to name. So back to the Lancet. They outlined on the first page the five principles of a realistic utopia, this ideal way of being with death and dying, globally, communally, individually. And so the top five, or the five that they identified, was that number one, that we look at social determinants, and I'll explain what that is, of death and dying and grief. And we really focus on that and address some of those factors that are non-medical that influence how we approach death, personally and collectively. Number two, that dying is a relational and spiritual process rather than just a medical event. How many of you have thought of that before, that death is not a medical event? Has that occurred to you? Or is it just something you take for granted? Okay. When I first heard that years ago, I actually, it was shocking in a way, because in medicine, when you go through the training, death is really the ultimate failure. And it is something that happens in our minds. You just are so focused that it's what happens when we can no longer sustain life because we don't have the right tools, not because it's a natural part of life, if that makes sense. So it's just ingrained in the medical culture that death is a failure. So many of the physicians you may work with or encounter may still have that mindset, that I'm failing my patient because I can't keep them alive. Versus acknowledging, you know what, this is an inherent part of life, integral to our evolution, and we will all face it one day. There's absolutely no training on that, personal relationship to mortality for medical providers. And I hope that shifts. I think it will. COVID did address some of that, or bring it to light anyway. And then this one, networks of care. So people's own social networks and communities lead the care for those dying and grieving. And number four is that conversations about death, dying, and grief become common, but they return to the dinner table. And death is recognized as having value. So we'll go into these a little bit more. So the social determinants of health. This one is, again, non-medical factors that influence a person's perspective on death and influences how they die. And those include, there are many that we may not think about often. So race, ethnicity, education, income, access to healthcare services is a big one, discrimination, oppression, sexual orientation. We know that certain races and gender preferences are skeptical of the medical system because of how they've been treated. And so they may not seek out medical support as readily. So those are some things. So just being aware of those and addressing them collectively is advised and encouraged. This idea of death not being a medical event, and remembering that it is a relational, spiritual milestone and a transition that we will all experience, and how we die matters. It impacts all of our loved ones left behind, and future generations is how I see it. I'm really focusing on relationships as a priority across all settings. Atul Gawande, have you heard the book Being Mortal? You all have? Wonderful. In it, he says, the experiment of making mortality a medical experience is just decades old. It's pretty recent, is what he's saying. It's young, and the evidence is failing. It is failing. So how can we get more creative around this process? So hospice and palliative care globally has come a long way. And I'm so impressed with this hospice program. I got to tour it and learn more about Assisi Hospice. Excuse me. And your guidelines are not as strict. In the US, our guidelines, excuse me, I'm just going to open this. Who qualifies for inpatient level of care in the US is very limited. So you all don't seem to have as strict criteria for coming to a place like this and to be surrounded by love. But in the US, we have pretty strict guidelines. And it's because Medicare, our national healthcare coverage, covers it 100%. So and then unfortunately it was abused. The system was abused. A lot of hospices made a lot of money, and so they had to get stricter, sadly. But that has impacted the care. So healthcare professionals can't substitute for certain things. The sense of coherence, like continuity of care, is not always guaranteed. Rituals and traditions aren't necessarily able to be provided by healthcare professionals due to time constraints, skill level, ability. And then the long-term care that you get from a community that's been with you all your life, you don't get from a medical community. So if we were to start really focusing on personal relationships and interventions and treatments being less of the focus, it would require a pretty big shift in our approach to death and dying. And we would want to really focus on the networks that surround the human being already and identify who are the people that are comfortable with death that could support you to stay at home. What's your church community? Is the church community comfortable being with you in these vulnerable times, or is it just kind of more comfortable to step back and provide food or something? Even that's valuable, but it's not enough when you're trying to stay home. So really tapping into local networks of care is the goal. And this, coming back to acknowledging death as a part of life, you know, so much of what people know about death and dying come from films and media, and they're not always accurate portrayals of death and dying. So the invitation would be to share stories about death and dying through film, in schools, with communities, and start having conversations on the global scale and the national scale. And evidence shows that if we start to talk about this openly and collectively, that people's attitudes will shift. People will become more familiar, more comfortable with death and dying. And what we're experiencing in the US is that the interest in death and dying has exponentially risen in the last 4 years. And people ask me, why do you think that is? So death doula training programs are abundant now, and the enrollment in that has increased 3 times. So like 3 times as many people are signed up to be death doulas, which is a non-medical supportive person who shows up for someone who's dying. And I think the interest is because many people are more, as our population ages, we're also experiencing more death personally, and that is shifting our perspective and reminding us of our own mortality. And somehow we're tapping into something greater when we're with someone who's dying. So having conversations is important. And I'm so used to, you know, having done this for 25 years, when I first started, people thought I was crazy. Even now, I was somebody, Grab driver, is that right? Grab the app. He picked me up from Assisi Hospice and he said, oh, what are you doing there? Are you okay? So there was a sadness and a kind of confusion about what hospice is and discomfort, really, with talking about it. So why I'm saying that is because if we talked about death around the dinner table, my brothers would be like, this is depressing. I don't want to talk about it, you know. So just remembering that it is an inherent part of life and important just to engage in dialogue about it. So remembering that death has value. Modern world does not recognize this. You know, all the anti-aging campaigns and our avoidance of this topic show us that we are afraid of it and we don't understand its place in the grand scheme of humanity. So rediscovering this value can help everyone involved in this season of life. And we know that without death, there is no life. And you see cycles of life, death, and rebirth happening in nature all the time. And then the more we acknowledge death as natural, the more we realize we are so interconnected and interdependent. And this is the one thing we all have in common, right? These are all common sense things, but when you look at systems level thinking and how the medical model approaches death, you realize it's actually not so commonly understood. Here we understand it, you know, but just remembering that even you one-on-one with people can have a huge impact on this conversation. So I looked up what was happening in Singapore on my long flight over. And the Straits Times, it's nice to see how much your country, your government supports the work that you're doing. It's really powerful and refreshing. And some quotes I'll share with you is that palliative care has come a long way in Singapore, but areas that need improvement are tackling the taboo, which we've talked about today already, around talking about death and dying, and bringing palliative care into the community. So the other challenges are that people are still reluctant to talk about death and dying. How many of you experience this regularly, this reluctance to talk about death? Just show of hands. It's still, so some of you feel like there's less reluctance, is that true? That's great, wonderful. And then this piece about choosing where you die. and enabling more and more people to die where they want to die. That still needs work. It's because one survey through the Lean Foundation found that about 77% of you all here in Singapore want to die at home, and in 2020, only 25% of deaths happened there. And also, we know that there's less caregiving support for people who are aging and dying because of the family units being smaller and also people being spread out all over the world. So combine that lack of support, caregiving support locally with the aging population. 1 in 4 Singaporeans will be, is that how you say it, Singaporean? Yeah? Okay. Will be over 65 soon. And we know that there's an increase in chronic disease burden. So people are going to be living longer with, like we spoke about earlier, with more chronic disease. So there's an urgent need to re-strategize and plan to meet the needs of your community. And they're also expecting more institutionalization, so more nursing home placement, if we can't meet the needs of your aging population, our aging. We have the same thing in the US. I think it's globally, actually, so I'll say our. We need out-of-the-box thinking, so it's time to get creative. And the good news is, home palliative care here in Singapore will be increased by the end of 2025, and I think the government's putting 23 million, is what the article said, within the next 3 years to make sure that happens. So then there's a transcript of a recording from the Parliament. The Ministry of Health was speaking to the government. This is probably preceding the grant of 23 million being to support this. And it honors that you all have come a long way with palliative care, but there are 3 areas that need help. And that is improving access, so making sure people are referred earlier to palliative care and have more access to the services, better supporting caregivers, which we've talked about, and normalizing these conversations. And I won't go into these too much, but they talked about this in that briefing, and you can just Google Ministry of Health Palliative Care transcript. They talk about increasing capacity, so making sure we have enough people to work in these fields, and looking at the financial sustainability and affordability, and making sure people access it earlier. In terms of supporting caregivers, that we know that that's the #1 critical factor in having people die at home, which is where most people want to die, remember? And there's so much stress associated with caring for a loved one. To be the full-time caregiver and to offer that 24/7 care while also grieving and seeing your loved one decline is very intense. So how can we support the emotional, spiritual needs of a family member? Looking at different financial options, and then this respite support. The day hospice program you all have here and elsewhere is really beautiful and powerful, and such a gift to the community. In terms of normalizing conversations, if we increase awareness and take action to help engage with advanced care planning conversations. I know you all do death cafes here. That's a wonderful way to get community members, again, non-medical providers or non-medical community members involved in the conversation. That's so helpful. And remembering that death is a social process. We have forgotten that because we have so medicalized death. We know what's important to individuals who are dying is being with loved ones, having regrets resolved, and final wishes fulfilled. So, again, I didn't want to go into this too much, but it's all there. So even as I was reading about all the initiatives with palliative care, it's still very much a medical approach to death and dying, right? It's still very much like we are responsible as medical providers. We're responsible for providing a service and doing this for you as a person who's dying, or for your mother or your father. It doesn't take into account that we as human beings and communities can actually start to do more on our own to support those who are dying and help shift the culture around death and dying. Does that make sense? There's a distinction. And so I wanted to introduce you to this concept of compassionate communities global compassionate communities. Have you heard of compassionate communities, compassionate cities? Great. So really, a compassionate city rallies around a dying person and their family. And the city, it's not just the medical sector, the healthcare sector that's involved in caring for this season of life. It's everybody. It's the schools, it's the farmers, or the restaurants, it's all the different people coming together to support the loved one who's dying. And it's expanding the model of end-of-life care to be just a healthcare problem, not a natural process. And acknowledging that it is everyone's responsibility to shift our approach to death and dying. It's not just the medical providers or the medical systems. And it's so empowering. When you think about this, what can you do as an individual in your own community to help shift everybody's, or at least one person's, approach to death? So we are challenged. Communities are being challenged to think creatively about how to find this balance between death, dying, and grief, and explore new models, coming back together as a village. So this idea of the wider civic society, everybody, and I'll share some examples in Kerala. You see the police force helping take a student to school when their mom is dying. So you see everybody rallying together to help support everybody who's impacted by the death of one person. And it's profound, really. And there's a lot of partnerships. And we do that a little bit with social services. I know where I live, if somebody doesn't have money to turn their heat on, we can talk to a local company. But it's not so integrated and sort of still spontaneous. It's not so organized. So that would be the shift, that we actually get more organized. So we're trying to build communities' capacity to take care of one another, basically, using our allies, our team of hospice palliative care providers, but really taking ownership of this process. And this is where the public health approach comes in. So historically, when we think of public health, what do you think about? Just throw out some names or things that are public health issues that we've addressed. Anybody? Sanitary issues, health. COVID was a public health crisis. So it's really everybody rallying together with a common purpose of addressing bad water quality, poor water quality. So it's a shift to even think of end-of-life care and death and dying as a public health issue. I don't think many people do think that. So if we start to look at it this way, then we start to look at the inequities and how some people don't have access and some people do. And that back to the beginning of the talk where we talked about some countries that have no medical care. We could start addressing that and expand our offering, just like we do food in impoverished areas. We rally around that to bring food to a poor community. So similarly with death and dying, we would rally and get creative. Compassionate communities are in 19 countries, India, Australia, Canada, and Europe and Latin America. So our community is not one yet, but I would love to see that happening. I could see Singapore doing it easily, because you are so cohesive, it seems like. Is that true? Yeah, okay, good. From the outside, it's my first time to Singapore. So I want to share about the US-based model that was mentioned, the Omega Home Network. So this is a model, it's a network of homes. During the AIDS crisis in the 80s, these homes popped up because people who were dying from AIDS had no place to go. They had the hospital kicked them out, families disowned them because of all the stigma associated with it. So if individuals opened up their house and gathered volunteers and started caring for these dying people. And over time, these homes became part of a network called the Omega Home Network. And it's really non-medical care for end of life. Home away from home for people that don't have caregiving support, or the caregivers are burdened and exhausted, and they just need a little help. So these homes are nonprofits funded by community and families and grants. And they work with the existing hospice team to provide care for residents. So essentially, volunteers become extended family That's how I look at it. It's not a hospital, not a nursing home, not a hospice facility, staffed by volunteers and in some cases paid caregivers. And you don't, whatever community opens one of these, they don't want to duplicate services. The goal is to work collaboratively and fill the gaps of where there's not enough support. And state by state, we have 50 states that are independently governed, and so every state has different regulations and guidelines. Unlike here, I think it's probably consistent, right? Which would be nice. So I founded one of these in Asheville, North Carolina, where I live, after taking care of Ethan. Because during that Ethan experience, which is captured in the documentary, people kept coming up to me and they were saying, Dr. Aditi, how can we do this for each other? Can we just buy a house and take care of each other? Can we support each other in this way through ritual, ceremony, laughter, joy, good food? Things that you do here, actually, based on what I've heard. Less so in the States, unfortunately. But it became really clear that the people who were showing up to take care of this man got so much more in return. Their lives were richer. My life has been richer doing this work. My connections, the joy that I feel by doing work with those who are dying has expanded. So, long story short, the Center for Conscious Living and Dying is a nonprofit. This is the home that was gifted to us to use by a benefactor. And it is a beautiful space. I'm not sure where to point this thing still. I just keep... It's really a community space, like a community center for people of all faiths, all ages. Children are running around, my children running around with 80-year-olds. It's really a place where we can show up and be together and connect with one another around what matters in service of those who are dying. So it enhances all of our lives. We founded in 2022, and we probably have 280 volunteers that are so hungry, just people like you and I, that are seeking community, that want to serve, that want to learn the skills to take care of people, to be fully present with one another. And we have gatherings and potlucks and socials and all sorts of things. It's really been a joy. And I'll share with you some of the, if it lets me, let's see. Good. And our care is free to those who are dying. And what we found is that many families give back so much more than we would have gotten had we charged. And so our services, we have community events that range from music to end of life for pets, that's a thing, breath work, International Association for Near-Death Studies. So are you familiar with near-death experiences and shared death experiences? So a place where people can gather. A lot of conscious living work. What does it mean to bring more death awareness into our lives? And how does that affect our relationships while we're living, before we're diagnosed with a terminal condition? So it gives you a sense of all the programming. This one is Science of the Afterlife in Grief. There's a lot of research around consciousness, and it's surviving long after we're gone from these physical bodies. So just a place where we can have these conversations where we're not considered weird and woo, like really out there. Because many of us have mystical experiences. Many of us have ineffable, unfathomable, you can't even put words to them. But we're not always given permission to share. So the more we can do that, the more we can stay connected to the mystery, the more. It varies for each individual what that does for your life, but yeah, it's powerful. I don't know what happened now. Let's see. Okay. So the neighborhood network in palliative care in Kerala, India, is one of the oldest, most amazing examples of how community can come together to make a huge difference in the lives of every member, not just those who are dying, but their families, their friends, their networks, collectively. So it's a South Indian state. 35 million people live there. So when you think about how can we make a difference, to think about it on this scale is powerful. You could change the world, by doing this. So India has about 60 million deaths a year. And this model basically a public health model for end-of-life care, started in the 1990s. And it has succeeded in all of these things. It has changed narratives around death and dying. It has mobilized and engaged a community of people around this season of life, and it has shifted how people engage with one another. More and more people have access to this care, palliative care, hospice care. The individuals who have been involved with this project have impacted government policy and on a national level, challenging models of care globally, and redefining care at the end of life as a public concern beyond services and beyond professionals. Everything we're talking about today, this is a success story. And so it's a symbol of hope for palliative care and end-of-life care and mobilizing community volunteers in another way, in a way that is low-cost, equitable, and participatory. That's the key. So Kerala, in their model, they say I'm jumping ahead, every volunteer is a leader. So one of the shifts in engaging communities is empowering individuals to get creative. You know your community best. So I would want to come to you as a hospice provider and say, what does your community need? And how can we engage your community to supplement what we're doing as a hospice team? And how can we really have a bigger impact? So here they talk about how they've engaged religious communities, local businesses, I've already talked to you about that, to really support individuals as a societal concern, not just a medical concern or a emotional concern. It has societal impact. Death and dying does. So at first they said that doctors and nurses were skeptical. And you can imagine some hospice programs might say, and this is what happened in Kerala, why do we need this? What we do is enough. And this is a similar thing that happens in my community with oncologists. They don't even understand why you need palliative care and hospice. They think they can do it best. So this is just listening to one another, hearing each other's concerns, having a conversation before othering everybody. It's time to come together and collaborate and really engage with one another and understand the fears and doubts and skepticism. And after a while, they are fully on board, all of Kerala. So people come to visit at the home, there's support for families and children, and with all the care. Resources are collected to support one another, food for the families, and then support even when the loved one dies. There's ongoing grief support. So it has fully transformed how people live and die in that state on a large scale. So now 1,600 institutions offer palliative care in Kerala. They have 2,000, of the 2,000 services in India, 80% are in Kerala. So 80% of India's palliative care is in this state, which is incredible. And they've trained over 10,000 volunteers. Can you imagine that many people? So then why would we need to institutionalize our elders if we could get creative around this piece? Not that institutionalization is wrong, and there's a need for it, of course, and some people need that level of care. But what about the people that don't need that level of medical care? We're always going to have people that need aggressive medical support. But for those that don't, that's where there's nothing to offer them. So that's where we can get creative. So, as we as individuals and communities start to increase our exposure to death, start to see it, start to engage with it, start to help people in this season of their lives, we will ultimately shift our own perspectives on death and dying and then can collectively come together to support one another, practically and emotionally. This public health approach is one solution. That community-supported end-of-life care model is one way to address the concerns that are present. And like I said, compassionate cities are emerging. Maybe Singapore could be one. It would be amazing. And I like this way of thinking about death and dying, returning to a way of being with death and dying that is so old that it looks new. So I'll open up for questions. Maybe a little early, but. Any thoughts, any questions? Thank you for being so attentive and listening. Yes.
Could you share a bit more about the pain management? I'm sorry to ask that.
No, please.
Oh,
Oh,
yes.
yes.
Manage the pain.
For pancreatic cancer? So, and your name? Your name? Nakeem. Nice to meet you, Nakeem. So Nakeem asked a question about pain management, specifically with Paula, my mother-in-law. So Paula was not averse to using opioids. Some people you meet might say, don't give me any of those drugs. It messes with my mind. It causes cloudiness, confusion. She wasn't opposed to using it. So she used very low doses of morphine. Pancreatic cancer is notoriously painful. A lot of abdominal pain. The tumor was wrapping around her blood vessels, causing a lot of kind of crampy pain. But with her, we ended up doing acupuncture to help. We used a lot of holistic modalities. Massage, CBD oil really helped her, a salve. We did sound music therapy for her. She loved music every night. We were 40 of us in the room singing to her and gathering. We did something, there's a field of medicine called anthroposophic medicine. Are you all familiar with that? It's Rudolf Steiner's work in Europe. And we were doing something called mistletoe injections, which is a plant. It's just an herbal remedy, but studies have shown that it actually helps alleviate pain. And you can do it subcutaneously. So we were getting creative. And her use of opioids, so mistletoe injections was another, aromatherapy, and so a lot of different modalities to help with pain and symptoms. And her use of opioids was negligible, very, very low amount. I was very surprised. I was ready for aggressive, And if her pain got out of control, we would probably need an inpatient level or would try to do it at home, but it never got that way. There was also, our energy in the room was calm and still. One of her sisters was dramatic and freaking out and and she would come in and you could just feel everything shift. And then she chose to leave and not be there the rest of the time. And I think that helps, the calmer the environment, if that's what the person who's dying wants, and she did. So, yeah, thank you for that question. Yeah. Any other thoughts about that? Yeah. I think that's the thing. I don't know how much you incorporate holistic modalities here in your work. Do you?
I think most of the people, when they come to that stage of pain, that they couldn't manage, especially caregiver, they send to hospital.
Yeah, and I think there's a place for that. There's some people that need that level. She was saying that some people, when their pain gets out of control, they end up going to the hospital. And so I think there is going to be those cases where the pain is so unbearable, especially bone cancer pain can be very painful. So I think you do what you can in home. I'm shy, I know. I'm shy too, you want to? Yes, sir. Yes.
It's the right to die. Euthanasia, this sort of thing, in your country origin or in Canada, where,
Sorry, I didn't catch the first part of the question.
The right to die.
Yes.
Okay, can you talk a little bit more?
Sure.
I think in the US, Oregon is the only state that's going to legalize it.
There are about 11 now.
11.
Vermont. Sure. So, first of all, I want to say, practically for you all, even if the right to die is illegal, you may get asked the question, can you please give me something to hasten my death, to let me get out of here. I don't want to suffer anymore. I'm ready. So even if it's illegal and we ethically and morally object to it, people are thinking about it. They want to know that there's a way out, that they don't have to endure so much suffering. So I want to just honor that. It's not something, it's very common to be asked that question. So that said, there is euthanasia, which is the active administration of a medicine to hasten death. A medical provider would give you an injection and you would die. That is not legal in the US. So there's a distinction. It is legal in Canada, Belgium, the Netherlands, one other place, I'm going blank, Switzerland. But in the US, the right to die, it's called medical aid in dying. It used to be called physician-assisted suicide, which is a term that is loaded, right? Suicide is very emotionally laden. We think of people, when they do commit suicide, it's often in distress, mental health issues, whereas the hastened death from a terminal diagnosis is often thought out, planned, very intentional, you know. So it's not called physician-assisted suicide anymore, but medical aid in dying. And it's now legal in about 11 states: Oregon, Washington, California, Vermont, New Mexico, DC, New Jersey, I think, is close behind, Montana. So there's some other states. And what it involves is the person has to be, well, each state has slightly different rules, but in general, 6 months or less prognosis, so terminal condition. Some states want to make sure you're not depressed and anxious so that they can address that with medications and therapies before you are given this medicine. You often have to put a written request in. So you say, I would like to get a prescription for these medicines, and you might have to wait 2 weeks and then reapply so they're sure you want it, you're serious. So it kind of is a system check, you know, just a way to keep things in check. And then you have to be able to self-administer the medication. So that's tricky. Yeah. So if you can't swallow because of progressive disease, then you're in trouble. There are ways that you can rectally administer it, but it's a little trickier. You don't know if it's going to work, or absorption issues. So the timing is important. So you have to self-administer. The provider can come and stir up the cocktail, they call it, and then you drink it. I know, it's funny. That's what they call it. And it's usually a combination of high dose of morphine and then digoxin, a medicine to stop the heart, and some medicine for nausea. So it's a combination of things. I don't prescribe, it's not legal in my state, so I don't use it. But
Not legal in Singapore.
yeah, right. Thank you for that question.
People who have got problem with swallowing, right?
Yeah.
So how would they be able to self-administer?
That's the problem.
Yeah.
So either you are so proactive, you have to time it so that you are able to administer it. That's the only way. Yeah. So if you have ALS, for example, and you already are on a feeding tube and can't swallow, that's tricky. They can't administer it that way. You can self-administer. So there are ways, but if you don't have a feeding tube and other things, then you're limited.
So will there be also another way, like if they are not able to swallow, will they go by
By injection, no. It has to be ingested. Thank you. So in a feeding tube is the other way, or rectal. I know. Yeah. Yes, no, one more.
Regarding regarding this, you share about this Kerala, India,
Yes.
that you got almost 10,000 volunteers,
Mm-hmm.
and how are they trained? Are you
Yeah.
able to share a little bit more about their training?
Yeah, so I'm not involved, but I'd like to go and learn more about it. Next time I come, I'll have more information. I think they have a pretty robust volunteer training program where the volunteers are prepared to go into the home and offer whatever care is needed. So that's all I know, but it's very robust and ongoing education. Yeah. And very coordinated with that many people, 10,000. Thank you. I may have an opportunity to go to Kerala this year, so I'm excited.
Hello, my name
Hi.
is Vanessa. Thank you so much for your
Vanessa.
talk. It was very pointed and meaningful. My question is, you talked a lot about how in families, the energy people give off like really influences the conversation on death. So I think I was wondering what are your thoughts about how do we change this almost generational sort of attitude towards it? Because like personally, my parents' generation, when I watched their parents pass away, it was still very traditional in a way, but they were very fixated on keeping the person alive as long as possible. And because of that, it sort of perpetuates the narrative that, as you mentioned in your talk very clearly, that death is very taboo, it's something to be avoided. So I'm wondering from your experiences, both in the States and in different areas in your work, what's the most effective way to kind of break that chain? Do you go straight to the young people and try to talk to them about it, or do you try to re-educate families? more holistically? And yeah, it's a pretty open question. I'm just curious of your thoughts.
It's a beautiful question. Thank you. You know, just like when we show up for somebody who's dying, we have to meet them where they are. You know, we can't impose our own beliefs. We can't force anything, which can be very challenging. I think that's a key, is meeting people where they are. So you can't really change somebody's mind by anything you say or do. It has to come from within them. But what I can say is that the more you empower yourself with information and you do your part to help shift the conversation, the more they'll observe you and your reaction when a loved one's dying and how you show up for them. Like with Jay's parents, with Jay's mom, nobody in her family, I've known them 20 years, nobody knew what I really did until that moment. And now they're supportive. So it's almost like the more we're exposed to another way of being with death, the more we will shift individually. And then gradually, the ripple effect is large. But in the meantime, getting creative with death cafes, music, films, really engaging in the conversation on your own and bringing it up, even if it may be uncomfortable and frowned upon. Like you can just test the waters every now and then and it might shift. So, yeah. I don't have all the answers, but it's all of us can sort of take the pulse on our own community and get a sense of what might work. And then let me know.
Almost the same question, but along the lines of not the families being not ready, but the patient themselves not ready.
Yeah. That was probably one of the most challenging things as a provider of this care for me, was acknowledging that no matter what I do, some people are going to die unhappy, depressed, anxious, with unresolved matters. There's only so much we can do. So I think the more you accept that we're not in control, but we can create the environment that's conducive to healing, and then whatever happens as a result is out of our control. So you're not always going to shift an individual who's dying's perspective, but you can love them, you can support them, meet them where they are, and they may die with unresolved things. It's just the natural. But I think the more we talk about death upstream, it impacts how we live. I have experienced less regret because of death and dying in my life all the time. I think about it all the time. And it impacts how I live. So the more we normalize death, downstream we'll see more changes to where hopefully there's less regret, you know? Hope that answers your question. Any others? Yes.
Thank you, Dr. Aditi. My name is Nanda. I am one of the nurses at Assisi Hospice, and I do home hospice care. And I'm quite interested in this volunteer program. I wanted to ask you, the volunteer at CCLD, do they provide, you mentioned that the volunteer will support the patients who are dying at the center, but how about for those patients who want to die at home? Do the volunteers, do they go there and then support the patients and also the family?
Yeah, it's a great question. So we are developing that program because most people want to die at home. But I think the model that I envision for that kind of support is us going into a family, a home, and seeing what resources and support they already have and mobilizing that. So if they're in a church community, let's educate the community how to take care of them so that they can increase their network of care, and then we can just come in and supplement that care. So I don't think we'd provide 24/7 care in the home. That's a lot to ask. So if somebody needs that level of care, let's say they live alone, many people are now aging without children nearby or no children at all, then they would probably need to come to the center because that we can offer that aggressive level of care, more intensive level of care. But in the home, I envision us creating more of a support network and empowering their community to step in. Because some people just don't know that they can offer intimate care. We're not used to it, asking for it. And it's uncomfortable for many of us. But you're gonna have to get that care somehow. Like there's no way not to get that care, so.
Yeah, so actually we also very interested in that because in Singapore there are quite a number of, we look after the patients who are alone, no family member, they want to pass away at home. So of course in Singapore there are support, caregiver support that MOH is providing. So actually we can collaborate. If let's say we can have a group of volunteers who are interested. Of course we are not looking at 24/7. We'll come out with the program that will cover for volunteers who are willing to do that with the support of home hospice and also the support of the care that provided by the MOH. Yeah, so we are very much interested. I think we are going to meet you later as well, and I'll ask you more.
Okay, sounds good. Good. I'm happy to hear.
Thank you so much, Dr. Aditi. Jacqueline, I'm part of Team Assisi. Very proud of what the team is doing here. Really. But there's so much to learn. And I was very intrigued by your sharing of the global compassionate communities. And you very kindly say if anybody can do it, Singapore should be able to do it. What's interesting and paradoxical is that so much is being done by institutions, by the state, and we know it's not enough. Because no matter how far we go, we can't enter into the world of the people who need to manage this, right, and die. So I was very intrigued by that and very touched by your initiative to start the Center for Conscious Living and Dying. So I was, really just humbly asking, what advice do you have for us as a first step to move towards this, maybe more an idea of asset-based community development, activating whatever sitting there in the block, in the vicinity, in the families, the dying person's own community. What's your advice? What were some of the biggest obstacles you faced when you started this center? What were some barriers that we are sure to encounter if we attend anything like that, which is more like a grassroots approach?
Yeah, thank you so much for that. Wow. Where to start? I mean, it really takes one person, is what I've realized. I thought I was just, what could I do as one person to make a difference? And it really, if you have one person from this conversation that wants to try to take this on, that's where you start, one person. And then you start having conversations and gather a group of people. I was surprised. I thought people would just trickle in, and it was like floodgates opened. As soon as I opened this idea, hundreds, and to this day, there's a hunger for this from a community grassroots level, not from a medical approach. So I think just seeing if somebody has the bandwidth to take this on internally in the hospice program or outside of the hospice program, and then starting to really assess the needs of a community. So going into the churches, going into the schools, seeing, you could start there, or you could just start one place, start small, and see what the interest is, start having conversations, doing talks like this. I think that it's just, you have to start somewhere, And for us, it was the doula training. I don't know if you have a doula training program in Singapore. Do you all? End-of-life doulas. Hospice is really, yeah. I know Henry, the last U.S. gentleman that came, U.S. expert, I laugh when you say expert, but no, I'm just kidding. He came in 2017, and he started a doula program, so he came here. So really, it's expanding the skill level of a volunteer, basically, so they can do more. So that's another way that training program has brought in people that aren't wanting to just volunteer for hospice, but maybe want to be more, have one-on-one connection that goes deeper and longer. So that's a good way to start. Assessing what interest you have in your spiritual communities, religious communities might be a good place too. Yeah. Thank you. You have an amazing infrastructure here at Assisi Hospice. I'm sure other hospices too, but I think it wouldn't take much, my sense. Maybe that's ambitious. I don't know.
Maybe one last question, anyone?
Thank you for your sharing. I'm Violet. I'm looking after seniors in the community. My question to you is actually I'm more interested in how you take care of your mother-in-law. Who does the coordination of the community, gathering people
Thank you. Yeah. So it's always helpful to have a point person. So even in the center where we are, it's nice to have a lead person. I happen to be that person for Jay's mom, my mom Paula, and for Ethan. And so yeah, you want to have somebody who can see the big picture and not get too emotionally wrapped up and can assess the needs. So it's a great question. That's where the idea of a doula, a lead support person comes in. And that could be another way to start internally when you already have so much support, volunteers built in. Maybe start to identify people that want to take more of a leadership role and have them get more involved at one person at a time. So that, yeah. I know hospice and palliative care does a great job on a population level, serving many people. This approach is a little more individualistic and one-on-one. So how to scale it, I don't think it's either or. That's where I think the collaboration comes in. So.
Can I just give you a comment about compassionate community? In Singapore, we do have an organization called Sound Foundation. So we are practicing this compassionate community concept in specific area called Wangpu. So Wangpu in Singapore.
Beautiful.
Yeah, so they're
I'd like to write that down.
community to do a compassionate community approach, but not specific to palliative care.
Oh, okay. Did you all hear that? There's a. Can you name that one more time? Oh, okay. Okay. I'd love to look at. Okay, great. Thank you. Thank you. All right. Thank you all. I look forward to connecting with you more this weekend. All right.
Thank you very much.
Sure.
And thank you very much for coming today. I hope you enjoyed the session, find it insightful, and hopefully inspires new ideas on how the community can come together to support people at the end of life. So before we, yes, a big round of applause. A few things to note before we finish off this session. Okay, first things first. For all of you, right? Do all of you have your registration pass, participant pass? Okay, at the back of